Hello, everybody, and welcome to our webinar around compliant coding. It doesn't equal lower reimbursements. My name is Kenan Rooney. I am your facilitator today. We will be having David Hullum and Kathy Egan presenting to you, and they're going to introduce themselves in a little bit around the topic of the recoveries and coding. And just to give you some logistics on this, we are being recorded. And if you do have questions, please submit them via the chat. You can earn 1 CPE credit today for this live session. 2 things you'll need to do. There are polling questions in here. You'll need to answer at least 3 of the polling questions, as well as participate for the duration of this webinar. The CPE certificate will be emailed to you within 2 weeks, and then we'll be sending you a survey after the webcast. Today's agenda, David and Kathy are going to provide the overview. They're going to talk about pricing and price setting, and then also talk about the alternative perspective on coding and coding audits. And then we'll have time for Q&A at the end. So with that said, I'm turning it right over to David.
Thanks, Kenan. My name is David Hullum. As you noticed from the slide, I'm a vice president in our healthcare practice here. I've spent probably about 2/3 of my career in industry. I've been a CFO, I've been a revenue cycle leader, and I've been a chief audit executive. So spent quite a bit of time in industry. So not just one of those folks that have, been in the consulting world and, only have that perspective. I've actually been across the table where you sit today and fulfilled a lot of the roles that many of you fulfill. So we wanted to share something different with you today. And that's why we chose to discuss different aspects or takes on pricing and coding. To start, I think all of you would agree that the healthcare revenue cycle is probably the most unique reimbursement model for goods and services that exists. I would challenge you to find a more difficult payment process than healthcare revenue cycle. I've worked in a couple other industries, and I can tell you that procure to pay and other things like that are nowhere near as complicated. So our discussion today is going to focus on a couple of different things. But first off, what I want to show you is that this is a fairly simple process that we overcomplicate. We do provide a service. We create an invoice. We send out a bill. We perform follow-up. The bill gets paid or it doesn't. And then we update the accounting records. Where Kathy and I want to focus today is that create an invoice area. That's why we're going to talk about pricing and we're going to talk about coding, because both of those things go into the creating an invoice area. Next slide, please, sir. We specifically included compliance in our title today, because it's always important to understand that when we operate and how we operate and when we work in this realm, we always need to keep compliance in top of mind. But we also want you to understand that in our world, compliance is not just OIG and CMS standards. Your organization has expectations as well. And when we talk about compliance, we also want to include your organization's expectations related to pricing and coding. So it's not just an on the island kind of an exercise. It's really something where there's multiple stakeholders in these topics, and we're going to talk about some strategies to address those today. Next, please, sir. So our discussion is relevant today for these reasons, okay? And Kenan, if you want to go ahead and advance those, go ahead and just all 3 of them, yeah. These outcomes have a very real impact on the health of the communities that these closed organizations or these organizations that are losing money, it has a very real impact on the health. So we're not just talking about the loss of jobs. We're not just talking about, organizations that are shuttering. We're talking about a very real impact on the health in these communities. The rural hospitals live on the edge of the reimbursement dollar. Those folks in those communities can ill afford oftentimes traveling to larger cities for their cancer care, their cardiac care, especially hospital stays. Those hotel visits, the meals, out-of-pocket meals, that's not covered by health insurance. So these kinds of reimbursement issues have very real impacts on our communities. Again, not just the loss of jobs and the shuttering of facilities. Next slide, please. So in our research to prepare this presentation to you, we found an article where Crow had performed a review. Crow LLP had performed a review of price differences across the United States for same services, okay? Any of you that have worked in this environment long enough know and understand, even in your own geographical market, that there are differences, okay? I think what we really need to understand from an aspect of our business is that our patients don't always understand this like we do. So we're going to talk about price transparency in a minute, but understand that, you know, a 297, almost 300% difference between the average highest and lowest charge for the same services is something that's very difficult for our patients. And we probably need to talk about them as being customers in this kind of new environment. It's very difficult for them to reconcile this. They don't understand the reasons why. Certainly, if you understand your cost drivers, that can be, you know, a factor behind that. But if it's really just purely competition, or because this is what our payers are paying us for these services, we probably need to have a better discussion. A $2,800 gap for the same ER billing code between certain areas is a very interesting concept for some of our customers to grasp and understand, especially if they're in the same geographic market. That equated to a 406% difference in the price of the ER gross charge and what they ended up from one organization to the other organization. And I definitely saw the comment about gross charges, but also understand your gross has an impact on your net, and your net is oftentimes way more, there's way more disparity on your net than oftentimes your gross, okay? Next slide, please.
This is our first polling question, everybody, for the CPE. I'm sending it off now. I'm launching it. Our definition of compliance includes which of the following? OIG CMS standards, B, our organization's expectations, C, our competitors, and D, both A and B. Two more, a couple more seconds here. Got most all of you. Great. Yes, the answer is D, both A and B, OIG CMS standards, as well as organizations' expectations. Okay.
Okay, so before price and price setting, before you can consider price and price setting, there's absolutely one thing that you must know, and it does not matter what organization, what industry you work in, and that is, Ken, please go ahead, is cost. So this is the dollars that are required to produce a good or service within the organization before you ever make a sale, okay? You know, the cost has multiple factors to it. In its most simplest terms, we really want to break this down and identify those areas that are variable costs. They vary by a unit of measure. You know, these can be a multitude of services or a multitude of drivers that we use to produce the service that we provide to our patients. So we're talking here, we're talking medical supplies, we're talking nurse and tech pay, physician RVUs, utilities, drugs, and test kits. If you've noticed on all of these, I've placed a driver out next to them. So medical supplies, fairly simple. You know, we're talking about the items that you're utilizing as you utilize them, makes them variable. Your volume goes up, you use more medical supplies. Obviously, it goes down, you use less. Same thing with your nurse, MA, and tech pay. Any hourly service that you that is based upon volume and the patients or the customers that you see, there's going to be a driver around that. And notice in a moment, we're going to talk about physicians because physicians typically don't get paid by the hour In some areas, they do. If your organization pays physician RVUs, that is another item driver that you can set out as a variable cost to a department, to a practice or whatever, however you break up those cost centers within your own organization. In some organizations that I've worked with, utilities are broken down by square footage. They'll take all the utilities, including internet, telephone, electricity, water, and gas, and then they make a variable cost allocation on a monthly basis by department, by square foot within the department, okay? Then also, obviously we have drugs, test kits, and other items that are based upon volume or per patient episodes. On the fixed cost is a little bit more difficult to pinpoint, okay? In a physician clinic, you've got exam tables, okay? The exam tables are depreciated. You can depreciate those and then you can allocate that by department. We know that there's 15 exam tables in family practice. So we're going to take the depreciation for those and we're going to allocate those out, okay? Same thing with buildings. We're going to allocate those by square footage, typically. Physician salaries are going to go by department. Building maintenance and repair, again, by square footage. Non-revenue producing departments like human resources and accounting have different methods for doing this. Some organizations do not cost human resources and accounting. Non-revenue producing departments are just considered a cost of doing business. I would challenge you that, human resources and accounting, especially in the healthcare delivery area with, hospitals and physicians, is a very substantial cost of doing business, and it should be considered in your price setting model, okay? The reason why I used FTEs as a human resource measure is because in most organizations, that activity can be pegged to the number of FTE resources that you have in your organization. And then in the accounting department, typically you would do a monthly allocation for the total yearly cost of operating the accounting department, from salaries, equipment, services, and all those other things. And then you make a monthly allocation to each department, either by revenue, or again, we can go back to a square footage model or an FTE model. It really doesn't matter as long as you're thoughtfully understanding what these drivers are and then, making these allocations. Next slide, please. So finally, after you've gone through and identified your costs, now you need to understand your volume. And this is kind of where you go in and you want to look at your current volume, and you would probably even want to have some what if analyses, okay? We need to understand how much volume in a family practice is going to cover our cost. How many patients a month do we need to see the cost to cover the cost to operate? And are we currently at that rate? If we're starting a new practice, completely brand new from scratch, you would want to understand, when are we going to start to pay back the investment that we've made in the facilities, in the procurement of the resources, the physicians and the nurses. For us, in healthcare, payer mix plays a substantial role in this, because we can't make these cost, volume, profit analysis without understanding what our payer mix is. Organization A is 75% Medicare, Medicaid. Organization B is 75% commercial. They're going to have a completely different cost, volume, profit analysis to get their break-even point, okay? Once we get our break-even point, then we can start making some decisions about price fluctuations, driving volume, things we can do to change our payer mix. These are obviously very important factors to understand where we are financially and how we're performing financially in all the departments of our hospital, which then feeds up into the overall profitability. If your organization's goal is to break even, you cannot do that unless you know what your cost and your volume are, okay? Next slide, please, sir.
David, there's a question in the chat, and and Kathy too, answering this too, is, are healthcare provider organizations doing better at cost accounting?
I would say what we see is the answer to that is unequivocally no. And I absolutely appreciate that question. I see, and I would love Kathy's perspective on this. what I see a lot of times is an accounting function in organizations that is completely separated from the revenue cycle organization as it pertains to cost, price setting and sharing of information. It's really odd to me sometimes when we walk in and the accounting department does not know what is going on in revenue cycle and doesn't have a say sometimes in what is going on as far as price setting is concerned, because the accounting department is the holder of the cost. They are the organization that holds all the cost. Kathy, your perspective?
I agree with you 100% on that. And I think that they need to coordinate a little bit better on understanding what that cost is as they're setting those prices in their charge description master. Of course, also looking at what reimbursement is from the payers as well, and looking at their contracts and using all of this information to help negotiate their payer contracts going forward.
Absolutely. And we're going to talk about payer contracts in just a minute when we get close to the end of this section. I am an accountant by degree and by practice. Started my career in that, and one of my jobs was cost accounting. Even the most basic premise of cost accounting and cost driving is being missed in a lot of our healthcare organizations today. And I think when we go back to that slide where we're showing a lot of these organizations failing, it's not just reimbursement. It's because we don't know and understand our costs, and we don't understand the drivers of that cost. So when reimbursement does go down, we don't really have any choice. Next slide, please, sir. So here we're going to discuss price setting strategies. And what I want you to understand is, and I'd like to take this back and challenge your organization to do this, okay? Marketing your services and marketing what you provide to your communities, there is nothing wrong with this. I mean, I look at a number of healthcare websites, and we're taking good credit for our reputation and all these other. What I don't see is oftentimes, we're a leader in cardiac care, we're a leader in cancer medicine. I see a lot of those things, but we're not talking about price, okay? We're not talking about why we're the leader, and we're not talking oftentimes about how we differentiate ourselves based upon price and service. So you can use some simple pricing strategies that a lot of other company or industries use, retail, manufacturing. Price skimming is setting an initial price high and lowering it when more competition enters the market. I actually worked at an organization, if you'll click ahead, Kenan, I actually worked at an organization that bought a Garnet scanner. It was the only Garnet scanner within probably 300 miles whenever these scanners first came out. And the quality of the imaging that came out of these scanners was far superior to what anything that existed in the market at that point. We didn't take advantage of that situation, sadly enough. We didn't go out and advertise the fact that we had this new revolutionary technology, and we could have, okay? And what I would have said at that time was, we can set an initial price for that and really bring in some business and bring in some extra revenue off of that, if in fact we have the ability to do that. Premium pricing is a little bit different. It's really for more boutique services. I would say it's probably a strategy that you would use more for non-covered services like plastic surgery, beauty treatments, and products. More and more healthcare organizations are starting to branch out into non-covered services as a way to supplement the revenue. And I think you see that oftentimes. Go ahead up to the next one, Kenan. In the value pricing area, especially like in the sports medicine and sports rehab areas, these are, again, traditional healthcare services, but we're now packaging them up and saying our sports medicine and our sports rehab areas, if you've got a university, lots of high school sports athletes, these are ways to differentiate yourself with the pricing and take advantage of the fact that you've got some of these reputational and organizations worth to be able to take advantage of, maybe setting some prices that are more than just competitive. Okay, next. Penetration pricing are strategies that you can use for, again, a new service, not like skimming, but you want to establish it at a rate that is more than competitive in order to get more volume, or it's a service that's declining. Maybe one of the reasons why it's declining is you go out and you look and your competitors are actually at a lower price than you are. And so maybe you need to lower that price in order to drive that volume back. Because again, when we go back to the drivers of the cost, your fixed cost is there as a burden all the time. If you're not seeing enough patients or customers for those services, you've got to do something in order to offset that fixed cost. And finally is competitive pricing. I would say that this is the vast majority of pricing strategy in the United States. As Kathy and I discussed a moment ago, oftentimes these organizations are not looking at cost. We're looking at what our contracts reimburse and we're looking at what our competitors charge, okay? If our competitors understand their cost and we're basing our pricing decisions upon what they're charging and we don't understand our cost, we're probably accelerating our ability to close our doors because we just don't know and we don't have a strategy for what we're doing as far as pricing is concerned. Next slide, please, sir. So once we've completed the cost gathering, the break-even analysis, and we have an idea of the price strategy that we want to employ, the next things that we need to do is we need to gather data on our competitors' prices. It's important to know that. We shouldn't just use that as our earmark, but we need to know it and understand it. And then if this is not a new service, we also need to understand what our contract reimbursement rates are for these services at this particular time. And then at that point, then we sit down and we review and we put all of this together and then we set a price, okay? Next slide, please, sir. So for our price maintenance, okay, once we've made the determination that these are the prices that we're going to go to market for the services that we're providing to our community, we obviously need to set goals. We want to align the price strategies and the services and the expectations. Next, please. Then we also want to build reports and gather data. We should all understand, physicians and accountants and other stakeholders, we need to have continuity with the reporting that we create because disparities, moving targets, things that don't look the same from the last discussion that we had about these kinds of things, that all creates a situation where people can't rely upon what it is that we're producing for them. We need to make sure that we're developing reports and information so that we can provide the best analysis at the time. Analyzing the data, develop the discipline to perform this step on time without exception. If you're going to review this information and these reports, and you're going to share information with stakeholders, do it on the frequency that you commit to doing it to. Don't put it off till next month. Don't put it off until next quarter. You need to do it. The reason why, next chevron, is change is constant, especially in this industry, right? Our costs are going up. Our competitors are changing. Our volume goes up and down. Our contracts get renegotiated. We have new and retired services. Why would we ever set a price, then just ignore it for 2 years? It just is not congruent with being able to stay as a going concern, whether it's a department or the whole entire healthcare organization, okay? Reassess, question, run what-if analysis, play games, look at things, change volumes, determine if the pricing strategy that you employed at the beginning now aligns with what you know about the volume and the number of encounters that you're starting to see with this new strategy. If it's not working, next slide. We want to communicate these results. We want to do that on a consistent basis. And we want to tell our users, and their stakeholders what's the most important aspect of this. Don't throw reports out into people's mailboxes, okay? Don't have a meeting if you've got a cross-disciplinary team that's looking at price and setting price. Just don't throw things in front of them. Lead them down the path, show them what's important. And then finally, you've got to close the loop on this. When you go through this the first month, you've got to come back and reset your goals, roll through the whole thing again. And I said monthly. Doesn't matter whether you do this monthly or quarterly or biannually, you need to do this at least more than once per year, okay? There's too much change that occurs in our industry to only look at price once per year. Next, please, sir. Finally, price transparency. Oh, could you back up one moment, Kenan? This information here, then this price maintenance strategy, I missed a point about contract negotiation, okay? This is a very important aspect of contracts and contracting and understanding where you are in the reimbursement world related to your contracts, okay? If you go into contract negotiations with your payers and they know more about your volume and they know more about your frequency and they know more about what's been reimbursed, they've already got a leg up on you. You need to be the most informed when it comes into going and talking about price and what your expectations are. You also need to talk about your outcomes. That is becoming the most important part of negotiating with your payers is your outcomes along with your costs. Next, please, sir. Price transparency. In setting our price, we need to take credit for a number of things. Again, we're going back into kind of a marketing phase as we're talking about price and price transparency. I've seen a lot of client websites that have prices for services listed out there, and there's lots of good comparisons going on, but there's no marketing occurring. You need to describe, your organization should describe the demographics of its market, the geography of its market, the organization's history within this particular market, and the value that that reputation and those services have brought to this community as far as healthcare is concerned. Take credit for any alliances that you have with medical transportation companies, outsource CT, MRI. Promote those organizations as well. And when they see that, they'll likely do the same thing for you, okay? When we're talking about price and services comparisons, it's not wrong for you to compare yourself to your competition. I would just say you probably shouldn't name them, and you definitely should not criticize or attack them. Those are not good ways to differentiate your services to your competitors. Finally, I'm going to skip to the bottom. Your customers are buying a healthy outcome, okay? Tell them why the latest technology is going to help that healthy outcome. Why are your providers better? Why is your reputation better? What makes service X at your organization better than your competition? And again, when we go back to those price setting strategies, maybe that is going to cue a customer to buy because of those factors rather than just price. Next slide, please, sir.
Great. We're back to another polling question. Let me set it for you. There we go. What is the most important element to consider when setting a price? A, competitors, B, contract reimbursement, C, cost, D, none of the above. Great. Thank you. Yes, the answer is C, costs.
So at this point, I'm going to turn the conversation over to my colleague, Kathy, let her introduce herself, and she'll go into the alternative coding perspective. And I appreciate your time today to listen to my portion of this. And now my colleague, Kathy, will take over.
Hi, everyone. My name is Kathy Egan. I am another vice president in the healthcare space at RGP. I have held various leadership positions throughout my career in revenue cycle, including operations as well as consulting pieces. So very happy to have you all here and ready to get going and talking about coding audits. Next slide. So typical coding audits. Most of us have probably experienced, talked about, or at least heard about coding audits. And you may be aware that typical coding audits are retrospective, after the fact, and typically consist of a specific number of accounts and account types with or without an established cadence. In many instances, the audit may only happen annually for a small number of accounts, and this doesn't really necessarily provide the information that we need to make sure that you're not leaving yourself open to potential risk or reduced reimbursement. Next slide, Kenan. There are various potential risks that these audits help identify so they can be corrected quickly. That's one of our goals. If coding audits happen too infrequently or do not consist of a statistical sample, you can start to load those, Kenan. We run the risk of both under and over coding, which both impact our revenue. Undercoding, of course, as you know, leaves money on the table in the form of decreased reimbursement. And overcoding poses potential payer clawbacks, fines, and in some cases, even prosecution from regulatory agencies. Next slide. So leaving money on the table, clawbacks or fines can have a big financial impact on your organization. Just look here at this projected payer takebacks for 2023. $15.8 billion increase over 2022. That's a 19% increase over last year. This year, they're projecting an increase of 23% in payer denials. And one of the things that totally surprises me is that a recent report indicated historically 65%, yes, 65% of payer denials are never contested. We could have a whole nother session on just denials. So this information makes it much more important for accurate coding, high clean claim rates, and this will help make sure that our billing and reimbursement accurately reflect the services that we provide. Next slide, Kenan.
Great. Just a quick polling question, everyone. True or false question. Third-party payers will make it easier to get reimbursed in the future. True or false?
And Kathy, while they're considering this question, I hope they all get it right. Your last slide, it was interesting. We could not find statistics on underpayments. CMS doesn't care about underpayments. They're like the IRS. If you get a refund, if you're supposed to get a refund and you don't file, they're not going to tell you we owe you money. So that just doesn't happen in our world.
Yes. Well, I hope those people that answered true were joking.
Maybe they're trolling us.
Yes, maybe. So you might ask, what is the alternative to a typical coding audit? 100% continuous monitoring. Every encounter from every provider is audited monthly or audited on a continuous basis prior to bill drop. I'm sure some of you are asking, how is this possible? It will require some technology and possibly a relationship with a vendor, and it is more expensive than auditing a set number of accounts per month or year. However, the benefits far outweigh the cost by one, identifying undercoding early to maximize your reimbursement, pointing out risk associated with overcoding and correcting that prior to billing, and identifying any coding issues and training requirements for new hires. And for value-based care, identifying your RAF or your HCC scores as well. Next slide, Kenan. So continuous coding monitoring, it's kind of hard to say, provides additional benefits related to both your revenue and compliance. With the increased cost of supplies, limited resources, and staffing issues that we're all experiencing, just to name a few, identifying matters that impact revenue is more important than ever, as David mentioned previously about the hospital closures and losses at the end of 2022. The continuous coding monitoring can also rank your highest impact specialties and your revenue producing areas and prioritize them for immediate action. So identifying these issues prior to bill drop can prevent or significantly reduce your denials, and you will be able to uncover potential compliance and audit risk, justify training, education for both providers and coders, and providers understanding some of the documentation requirements that need to happen in order to code appropriately. Next slide, Kenan. So there are several benefits to continuous coding monitoring. Automating the audit process provides the opportunity for reviewers to concentrate only on problems, making their time more focused and efficient. Coding related denials can be reduced since issues should be caught prior to billing. We know how much working denials cost. The rework as well as rebilling is an additional cost to us that we want to avoid. And these systems also provide data and graphical information to enhance coder and provider education and training, with which adequate feedback should over time reduce our coding errors. And I think we have another polling question.
Oh, yeah, 1 second. Can we back up one slide, Kenan?
Sure.
I think it's important for everyone to understand from a strategy perspective. If you're sitting in the compliance function, or compliance is a very strong and serious issue with you, I think it's always important to understand that when you're performing audits, you should be looking for undercoding. And I think one of the ways that you can cost justify bringing in an application or a third party to support you in your compliance realm is the identification of missed revenue. That can be the hedge for what pays for your compliance process. I mean, let's face it, the exposure for compliance is sometimes greater than the missed revenue capture, okay? But when you're talking to a CFO, and I'm a former CFO, so I can say this, a lot of times I'm only looking for those things that are actually going to enhance my revenue or reduce my expense. Something that could happen, like a CMS fine or an OIG case or something like that, that's something that I'm going to consider to be less likely. But selling me on the fact that these services can actually increase our revenue to the appropriate level because we're undercoding, that's something I might be interested in hearing about.
Yeah, and I think doing it continuously prior to bill drop, even though that cost is a little different, it's much better than post billing and kind of going back and hiring a third party vendor to come in and review your accounts that you have already billed to look for that lost revenue or that undercoding, because then you're having to also rebill those accounts, and there's additional cost to that internally as well.
Yeah, I think, Kathy, when we were discussing putting this together for this discussion, I think the thing that you and I both agreed on is we could probably have a whole different 1 hour session just on pre-claim submission. I mean, yes. That's really what we're talking about. In a lot of these instances, we're just dealing with it on the back end more than we are, trying to adjust it and hedge it on the front end. So that maybe that's a future topic.
Yes, yes. Okay, Kenan, you can move on. I think next slide to ready your polling question.
This is our last polling question, everybody. Not second to last polling question. We have one more after this. Coding audits and reviews should focus on which of the following? A, compliance, B, problem solving, C, revenue, or D, both A and C. Great. Yep, the answer is D, both A and C.
Okay, I don't know, David, if you had any more things that you wanted to add, especially to some of the pricing issues that we talked about related to charge description master, or if we have a few more things that we want to talk about with the continuous coding monitoring.
Yeah, there was a question that I saw, and I apologize. I tried to respond to it, but it evidently didn't go back to the viewers. I think the question was, does RGP have the capability to review all CDM line items, descriptions, prices, including drugs, supplies, and all those other things? The answer to that very simply is no. However, we do have a number of alliances and relationships with organizations that provide that service. They are out there. We actually do work with a number of them, a couple in particular, and the service or the value that they provide for being able to do that is very good. It's a very worthwhile investment. And I would encourage you, if you don't have something that's looking at your charge description master on a frequent basis, I would very much encourage you to do that. Not only from a compliance perspective, but then also too from a description perspective, and then a pricing, and then a unit of pricing perspective as well. We see a lot of mistakes where people are, they don't get the unit pricing right whenever they're updating their charge master and their charge master descriptions.
Or the number of units that are required on a claim.
Exactly.
Right. There's a lot of errors on that. And that's part of some of the line item denials that we've seen. When we talk about the continuous coding monitoring, there are vendors and systems out there that have the availability to look at your coding prior to bill drop, which is one of the things that I think really helps reduce your denials and reduces your risk for compliance issues and audits. They can identify different items based on your very specific work that you do, your specialties, and what you think are your highest revenue and highest impact specialties. And they can prioritize those for something to be sent back in work lists, coordinated with your EHR, or however you do your workflow management, and make sure that those get to the right coding reviewers to correct those. One of the things I think is really important is not only using a system like this and having your reviewers or specialty coders fix things, but a feedback loop that goes back to your coders that are initially doing the coding, so that over time those errors start to get reduced. And we did mention that it causes, or it helps you provide information on what coders need education, what education that they need. And I think that's really important if you have a training department internally, or some of these vendors also will perform training for both coders and physicians in documentation, so that you can stop all of this, reduce a lot of these errors going into your coding over time. Some of the instances that we have, and you all know, if you have coders, that the coders cannot lead the physicians when they're asking them questions through queries, but these people that do this information and the people that can address the training for our coders and our physicians with documentation can really point out what the differences are in the documentation requirements for a coder to code. The coders have rules they have to follow. Physicians have documentation rules that they have to follow. And sometimes there are templates within our EHR and where we document, and some of those need to be updated. I have some very specific examples of things that the coders were asking questions, but they couldn't lead, and they couldn't ask the questions specific enough to get the physician to be able to document his services, where we could code both an E&M and an office visit and the procedure that he was doing. So there are definitely some benefits to providing this information or getting this information prior to bill drop, and feedback both to the physicians as well as the coders.
Kathy and David, can you speak a little bit about the responsibility of the QA, or the importance of the QA roles within these organizations? The reason why I'm noticing there's a little bit of an uptick too for the creation of, or more focus on building a much more robust QA group in a lot of our clients.
Well, Kathy talked about the value of pre-claim, and I'm going to even go a step further. I think probably some of the most rewarding and successful jobs that I've worked on as a consultant are when we connect the front end to the back end, when we connect the billing and the pre-claim audit process and review process to the resulting that comes in off of our electronic remittances, and then we use that to drive conversations about coding, both physician and coders. Okay. We talk a lot about revenue integrity, but unfortunately what happens with a lot of revenue integrity departments is they've just become the fixers of all the problems and the issues, and none of that information ever gets communicated to the areas that are actually causing the issue, that are causing the problem. Okay. I think more time and effort has to be invested in educating not just providers, not just coders, but all stakeholders on the challenges that come whenever we're talking about configuring a billing scrubber or a pre-claim scrubber before stuff goes out the door, and then how the results of the success of that effort come in through the 835s, I mean the 837 on the denial side of it, right? Or on the RARC and the CARC codes that we get result. A lot of times we don't close those loops. And so for the QA to work and for the QA to be the most effective, we need data, just like I showed in that one slide. We need a process where we're analyzing that data, we are setting goals, and then we are taking that back and redoing the process again and communicating on a frequent basis.
I agree. And that's not just with our coding and our physicians.
Oh,
That's the entire revenue cycle.
it is.
We need that feedback loop to the people that are doing every bit of this, where we find errors that are causing denials, lower reimbursement, or compliance risk. All of those pieces within the revenue cycle will really benefit from appropriate and timely feedback.
Exactly. I think one other thing I'd like to add, Kenan, about pricing is, in the contract negotiation part of this, if you're not engaging the group of individuals who are actually sitting down and negotiating the contracts from a revenue cycle perspective with the things that are getting underpaid and informing them on how the third-party payers are actually not performing and not adhering to the contract terms, that's very important information. But again, the commonality in all these discussions is feedback. It's effective feedback. It's effectively gathering that data and then using it to drive change. If we're accepting all of these things, like Kathy's slide showed, 65% of denials are never resubmitted. That's a major failure in the communication and feedback loop.
Yes.
Hey, everybody, we have one more slide left, and it's a general question that we wanted to ask, but then we're going to open it up for Q&A. And it's another polling question that I think will help us kind of get a sense of where all of you who are on this call are in your journey. So the question is, where are you in your revenue cycle optimization journey? I haven't started, but we plan to do it internally. We haven't started, but we need help. C, we started and we're doing it internally. D, we're started and using outside help. And E, we don't plan to change our current processes. And while you are answering this poll, if you want to, we're opening it up for Q&A now. If you have any questions, I think I have to unmute you, raise your hand or put it in, and I will unmute you, and then and we can have you articulate your question.
One of the things we hope we accomplished today was, I've attended a lot of webinars in the past, and many times you attend the webinar, you hear the information, and it's something you already know. You didn't learn anything new. So I'm hoping what we had tried to accomplish today was something a little bit different, a little bit outside the box, and hoping that you learned something new and picked something up. So if you want to let us know what that might have been for you, that would be great.
So a lot of you, it looks like, are starting, 50% started and they're doing it internally. So there is,
Great.
really optimization going on. So
That is good to hear.
Stop sharing. So you guys, very much appreciate your time. Do you have any questions? Reach out to the RGP person that invited you, or any of us, or partner at rgphealthcare.com. We are available for questions right now. We've got a couple minutes here left to take anything that you have for Kathy or David. Okay. Well, thank you very much, everybody. We appreciate it. We hope we're giving you clearly that you've had value in this webinar, but also giving you back the gift of time. So thank you very much. Have a great rest of your week.
Thank you.